Hi again. In this discussion, we'll be talking about your diverticular disease. When I talk about diverticular diseases, there are three terms that we need to be familiar of. One, diverticuli. When I say diverticuli, these are herniations of the colon mucosa. Two, diverticulosis. These are outpouchings, but take note of the term non-inflamed. Because once there is inflammation, it is already referred to as diverticulitis. So, your diverticulitis is irritated, inflamed, it may be infected, tender outpouchings, okay, that lead to abscess formation and fistula formation. Assessment findings for a patient with diverticulitis, okay, or any diverticular disease. They will have pain, change in bowel movements, there is increase in flatus, anorexia, there is low-grade fever once your patient is already developing diverticulitis. There is pus, okay, especially if the patient has infection, still diverticulitis, and then presence of mucus or blood in stools. So, this page would orient you on what is a diverticula. So, a diverticula is most common in the sigmoid and descending segments. They appear as small pouches on the colon walls. Okay, so these are the small outpouches in the colon walls. They usually diminish in number and size as we approach the cecum, okay, and they rarely develop in the rectum. So take note of that. Now, the close-up illustration here shows the narrow neck that connects the diverticular pouch to the intestinal lumen. So meaning this neck is connected to the intestines. Meaning the tendency is that your patient might have some food products here, might have some infectious products here that may go inside the diverticula. Okay, that's why your patient would have or will be at risk for having diverticulitis. So this is another example of your or illustration of your diverticula. Okay, so this is an obstructed diverticula opening. Now, what will be our management for this patient? In mild cases, high fiber diet would work. Okay, we don't want food to be stuck up there on the diverticulosis. So we want it moving. High fiber diet. Then prevention of constipation with bran and bulk laxatives. In acute cases, you would need to place the patient on NPO. Gastric rest for that matter. NGT insertion may be needed. And then IV therapy. Okay, just to make sure that the patient is receiving adequate fluids. Then medications, if it is diverticulitis, you would need antibiotics. Surgery, okay, is done if there's presence of complications. Okay, usually it involves ligation and removal of the sac or resection of the involved bowel. Okay, meaning it is possible that the outpouching that your patient had, okay, will be removed. Okay, this outpouching will be ligated and removed. Or if not, the colon where the outpouching is will be cut, okay, involving resection of your involved bowel. And then colon resection with a temporary colostomy for that matter. The nursing management, we administer antibiotics as ordered. So common antibiotics for the GI tract surgery would involve your metronidazole. You also have your ciprofloxacin and your Bactrim. IV therapy, of course, and then Demerol as the analgesic of choice. Because your morphine, also a very good analgesic, is not given or contraindicated because it increases intraluminal pressure. And we don't want intraluminal pressure to be increased this time. Then, diet. High fiber. Avoid food with seeds because seeds may go through the diverticulosis. Bulk forming agents such as your metamucil may be given. During an acute attack, bowel rest is recommended. So when I say bowel rest, the patient is on NPO. And then an NGT or TPN will be inserted. NGT is for gastric decompression if ever needed. TPN will serve as the temporary source of nutrition. Laxative and enema is contraindicated. But if you would recall on the previous slide, there's a part there that would say that enema, laxative, could be used. With that being said, there are several types of laxatives. Okay, there are actually 4 types of laxatives. Among these 4 types of laxatives, what do you think can be used in diverticulosis? Okay, try to answer that. Then surgery would involve again bowel resection with anastomosis or ligation of the sac. Other nursing interventions would involve increasing fluid intake, 2 liters per day, soft high fiber still, set time for defecation, train your patient when to defecate, and an established schedule for meals. Okay, because they say defecation is a habit. Okay, if you're accustomed of doing it every morning, okay, you can do it every morning. That will be able to help the patient to schedule her defecation. Then stool softeners and oil retention enemas may be indicated. Analgesic. Again, what is the analgesic of choice? That will be your meperidine or Demerol and not your morphine. And we monitor for perforation because once our patient has diverticulitis, there is a tendency for the small intestine or the large intestine to perforate. Okay, we don't want that to happen because the contents of our intestine would go to our peritoneum. It's a big no-no. Okay, so this is an example of a bleeding diverticula. Then, this is an example of a resected colon with diverticula. So when I say resected colon, okay, as you can see, this part here will be removed, okay, where the diverticula is, okay, and then they're anastomose. Okay, that's it for diverticulitis and diverticulosis. Just take note that the difference between the two is inflammation or infection. Let's talk about hemorrhoids. There's a lot of patients having hemorrhoids. So when I say hemorrhoids, they could be of two types. It could be internal or external. But what are hemorrhoids? They're simply varicosities, okay, of the hemorrhoidal plexus, which drains the rectum and anal canal. In other words, they are varicose veins inside your anus or maybe outside. Okay, perianal varicose veins. Causes. This can be caused by constipation, okay, prolonged straining. Okay, because of prolonged straining, venous return will not be good. Okay, and then because of that, there will be engorgement of your veins. Obesity is a major risk factor. So as pregnancy. Obesity and pregnancy both increases the pressure, okay, towards your vein. Then you have prolonged sitting and standing. Okay, either of these positions also increases your risk for hemorrhoids. That's why it's not recommended to stay on a single position for a prolonged period of time. Now, so there are internal hemorrhoids and there are external hemorrhoids. So external hemorrhoids could usually be palpated by our patients. They would complain that they have palpated something irregular in their anus. Internal hemorrhoids, no. Okay, usually the patient would complain of irritation. Okay, but later on it will be discovered it's internal hemorrhoids. So pathophysiology. Because of the straining during bowel movement, maybe obesity and then also pregnancy, there is an increase in intra-abdominal pressure. This increase in intra-abdominal pressure would impinge your veins, leading to the distension of your hemorrhoidal veins. Okay? And later on in the long run, if that continuously happens for a prolonged period of time, there will be permanent dilatation of your hemorrhoidal veins. Assessment findings. There's an enlarged mass at the anus. There's sometimes blood, bleeding. There may be prolapse, especially if the hemorrhoids is too big. When I say prolapse, the hemorrhoids is going out of the anal cavity. Rectal itching, constipation, pain, especially if there's presence of thrombosis. So when I say thrombosis, meaning the blood inside your hemorrhoids are already clotting and bloody stools. Medical management. We prevent constipation through dietary changes. You don't want these patients to be constipated. Okay? They will experience pain because after all, the constipation might pass through the part where there are hemorrhoids. You don't want that to happen. So you give a hot sitz bath. So your hot sitz bath is preferably done after surgery, after hemorrhoidectomy. Hemorrhoidectomy is among the painful surgery your patient may undergo. Then you have stool softeners, okay, Colace and L-Axoberal for that matter. Then topical anesthetic or steroid preparations may be given. So usually, of course, inserted directly or placed directly to the hemorrhoids. And then as I have mentioned, surgery, removal of your hemorrhoids, which involve hemorrhoidectomy. Now, try to find out what are the client teaching post-hemorrhoidectomy. What is the best position for the patient to assume after hemorrhoidectomy? And what are the nursing care done after hemorrhoidectomy? Okay, so you have here promotion of healing, prevention of complications. What are those complications? And then pain relief. What do you think is the remedy for pain relief post-hemorrhoidectomy? Then we also have one procedure referred to as rubber band ligation of your hemorrhoids. So in rubber band ligation, a ligator is inserted through a lighted tube. And then this ligator, will grasp the hemorrhoids. Okay, grasp the hemorrhoids with forceps. And then it is slided upward to release the rubber band. What is the purpose of the rubber band here? The rubber band is expected to cut off the blood supply going towards the hemorrhoids. And when the time comes, it will just fall off. Okay, once there is no more blood supply. Okay, so that's your rubber band ligation of your hemorrhoids. So far, that will be the end of our discussion on your gastrointestinal alterations. We will be seeing each other on the live session to discuss some of your queries and to recap on some of the important concepts and to reinforce what we have learned. Level 3, once again, thank you very much for your attention.